Hello everyone, this is Seher again from Dentabest.com, and we are here to do prosthodontic review today. As we know, prostho is a very vast subject. It has different topics in it, and we'll try to make it as comprehensive as possible for you. So these are the topics that we are going to cover, which include your RPD, your complete dentures, your overdentures, fixed partial dentures, cantilever bridges, pyre abutments, Maryland bridge, veneers, dental implants, and the overdenture, along with the dental materials too. Now we can see different components of the RPD, which include major connector, minor connector, direct retainer, indirect retainer, replaced teeth, and the denture base. So major connector, as we know, they are connecting between both sides of the arches, and they should be rigid so that any stress applied to the area of denture can be effectively distributed over the entire supporting area. The minor connectors, which are rigid component again, that is connecting the major component to other components of the RPD like direct retainer, indirect retainer. Then we have the denture base, direct retainers that are the class, suprabulge, infrabulge class that give retention so that the processes doesn't come out. Then the replaced teeth made up of acrylic or porcelain that help in restoring the masticatory efficiency, maintaining the aesthetics, and preventing the migration of the remaining teeth. And then we have the rest and the rest seat too. The rest and the rest seat, they mainly provide the support so that your denture doesn't hit into the gingiva and doesn't move tissue wards movements. It will prevent the tissue ward movement. Now we can see the design of the direct retainer here. So this is the clasp assembly, which has the retentive arm in it, clasp arm that gives the retention. This is the reciprocal arm that will reciprocate or balance the action of retentive arm, so that when retentive arm is active, no orthodontic tooth movement can happen because reciprocal arm will reciprocate the action of it. All the parts of the RPD framework, they are rigid except the retentive arm that's going to be flexible. Now this is the minor connector. So there are four parts of the clasp assembly: minor connector, rest, retentive arm, and the reciprocal arm. Now there's the indirect retainer too, right? So indirect retainer we are using only for Kennedy class 1, class 2, and the main function of the indirect retainer is to prevent the rotation of the denture base around the fulcrum line. So fulcrum line, as we know, it's an imaginary line passing through distalmost occlusal rest around which the denture has tendency to rotate. Now you put a perpendicular to that fulcrum line. Perpendicular to the fulcrum line where it ends, like on the mesial fossa of the premolar or the cingulum of canine, they are considered to be the ideal location for putting an indirect retainer. But always remember, indirect retainer is only used for Kennedy class 1 and the class 2 design. You can see more details here. Now direct retainers are divided into intracoronal and extracoronal. Intracoronal is like precision attachment, semi-precision attachment, that's a topic of FPD when we discuss about it, and the extracoronal with the retentive clasp arms and the attachment. Now you can see this is called as the RPI design. That's also very important design, always asked in the exam, which has the mesial rest, proximal plate, and the I-bar. So it becomes the RPI design. So you can see this I-bar is the infrabulge design. That's approaching the undercut from below the height of contour. This is a gingivally approaching class we have. Proximal plate is your guide plate. It's approaching the undercut from distal lingual embrasure. And this is your mesial rest. So what's the main function of the RPI design? RPI design again is most commonly used for Kennedy class 1 and class 2 design. So using this design, the mesial rest proximal plate will provide the reciprocation. So when the occlusal forces, they act on your abutment tooth, the reciprocation action of mesial rest and proximal plate is going to disengage the I-bar proximal plate from the tooth surface, so that the forces are not falling on the abutment teeth, they are falling on the tissue denture bearing mucosa. So they will push the processes more mesially and gingivally. So that will eliminating the pump handle effect. That's a very important effect that you can go through further in my notes. This is the RPI design. Okay, so before we proceed with the maxi denture, I would like to add more point about the occlusal rims made up of wax that help in determining and establishing patient video and the level of occlusal plane and making the preliminary jaw relations. Inferior surface of your maxi occlusal rim should be parallel to the Kemper's line, that is from ala and tragus, and anteriorly we should know it should be parallel to the interpupillary line. Also, there are three impression techniques that we have for taking the impression in the complete denture. The one technique we know is the mucostatic technique. Second one is the mucocompressive or the functional impression technique, and third is the selective pressure technique. The selective pressure technique that is most commonly being used, where you're going to apply more pressure on the stress bearing area like your ridges, palate, buccal shelf area, rugae, and you're applying less pressure or relieving the area like foramens, midline palatine raphe, sharp spiny ridges, or torius. Now, for the mandibular denture, the main issue is to have a good stability and support. So having good stability for the denture, mandibular denture is little tricky because you also have a tongue there that try to destabilize the denture and also the resorbed ridge. That's the reason you want to cover as much as basal bone as possible to improve the stability of your mandibular denture. Now, the mylohyoid muscle can affect the lingual flange of your impression, the molar region of the mandible, and there is something called as S curve that is formed by two curves in opposite direction. The one curve which is sloping towards the tongue, the mylohyoid muscle, and the retromyloid fossa who is sloping towards the buccal area. Now, when we talk about the maxillary complete denture, we can see the primary support area is ridges and palate and secondary is rugae. Now, main thing we should know how to record the posterior palatal seal. So, posterior palatal seal is a very important landmark, very important point for your maxillary denture, because maxillary denture, the most important property is to have a good retention. So posterior palatal seal area, the function is to complete the border seal of the maxillary denture to prevent the food impaction beneath the denture tissue surface to improve the physiological retention, and also the posterior palatal seal is going to compensate for polymerization and cooling shrinkage of the denture resin during processing. Now, how to record the posterior palatal seal? For that, you have to record firstly the anterior vibrating line and the posterior vibrating line. See, anterior vibrating line is also called as a blow line when you ask the patient to close the nose and blow, or ask him to say ah 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 in rapid vigorous burst. This anterior vibrating line will be in the form of a M. It is at the junction of the hard and soft palate. Now for posterior vibrating line, you ask the patient to say ah ah in regular burst. And this vibrating line in the form of a gentle arc will be at the junction of movable tissue of the soft palate and the non-movable tissue of the soft palate, but it's entirely on the soft palate. So it will make like a cupid bow. So the area between the anterior and the posterior vibrating line is actually the PPS, or the posterior palatal seal area. Flatter the palate, wider is the posterior palatal seal. Now you can see some more points here like Christensen phenomena. So when you're doing the protrusion or anterior movement of mandible, the space that opens between the posterior teeth, usually between the premolars, you can see that. Now we can see some of the definitions here like unilateral, bilateral, balanced occlusion. So bilateral balanced occlusion is a stable simultaneous contact of the opposing upper and lower teeth in the centriculation position with a smooth bilateral gliding contact to any eccentric position within the normal range of the mandibular function. It is mainly done to lessen or limit tipping or rotation of denture base. In the bilateral balanced occlusion, you have maximum number of teeth contact in all excursive movement, centric and eccentric position. That is best for your denture stability. Now, we should also know some of the factors that govern the establishing balanced occlusion, like inclination of condyle guidance, inclination of incisal guidance, occlusal plane, convexity of compensating curve, and angle and height of the cusp. Now we know what is group function. Group function is when the canine and the posteriors they contact on the working side, disarticulating all the posteriors on the non-working side. That is also called as unilateral balanced occlusion. Okay, so here we can see different types of face bow like arbitrary or kinematic face bow. Arbitrary bow, that is most commonly being used. It is accepted by semi-adjustable articulator, while kinematic is mainly for fully adjustable articulator. The main function of the face bow is to record the relationship of maxilla to the transverse hinge axis. Main function of the face bow. So you can see the design here, and also you can read the indication of the face bow. Okay, so on this slide you can see different type of bridges, in which the first one is cantilever bridge, that is abutment at only one end with a pontic attached to the other end. And definitely for putting a cantilever bridge you should have a strong abutment. For example, you are replacing a missing maxillatral and using canine as an abutment. It's the most common case of cantilevering. Now you can see this is your Maryland bridge, and it's a conservative resin retained FPD with solid metal retainers that relies on the edged inner surface and the enamel of the retainer for its retention and giving the groove form. So in children you can use this resin retained FPD. They are only used for replacing one or two missing mandibular incisors, or used as a splint, or replacing a single posterior tooth. You can see it's like a wing-like preparation. We can see encompasses at least 180-degree, and vertical stops are used for providing the resistance and the rigidity along with the grooves. But the patient has deep vertical bite, extensive caries, nickel sensitivity, you cannot use it. Reduced cost, no anesthesia required, and the margins have to be supragingival in case of Maryland bridge. So basically you're not preparing the abutment tooth at all here. This is a Rochette ridge, which is a wing-like preparation with a funnel-shaped perforation to increase the resin retention, and combined mechanical retention is provided with a silent coupling agent to provide adhesion to the mat. Now we can see here, this is your pier abutment. So pier abutment is a freestanding abutment with the edentulous space on either side, and it requires a non-rigid connector. The reason is that pier abutment can act like a class 1 lever. So having a non-rigid connector, a keyway design will be helpful. It is a broken stress mechanical union of a retainer and the pontic. But pier abutment, as we know, it can only be used for short span bridges replacing only one teeth. So you can see the key and keyway design here. Hi my dear student who are preparing for IMD ADAT or Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the Dentabest channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from Dentabest, wishes you all the best for exam, and thanks again for watching.